ASMR. It's your girl, Bibliophile, and I'm back. Thank God I finally have the confidence and the willpower to make this, and it is all thanks to my literal babe, Jingle Jangle ASMR, who posted a video today that I watched, and I was so motivated by her. I was like, bitch, I must. So, let me start off by giving my Patreon, my Biblio babes, a quick shout out. You guys, thank you so much for being subscribed to my Patreon account. I am posting a new video there in just a little bit. I would like to give a shout out to Shelby and Daniela, as well as Dory. Thank you guys so much for being Biblio babes over on my Patreon. I just had dinner. So thank you guys so much. So if you guys want, I'm going to be posting a little update over there right after I finish this one, because your girl's feeling motivated. I might as well just get a video out on both sides. So I'm going to do that. But this video is going to be talking about some preventive medicine stuff before my quiz tomorrow. So we are going to be going over what preventive medicine is and some of the screenings, as well as some immunizations that I'd like to go over. So I hope you guys are doing well. First of all, let me just get a sip. I hope you guys are doing so well. So preventive medicine basically is disease prevention on a multitude of disease prevention on a multitude of levels, 5 levels to be exact, and they're all different meanings. So we've got primordial prevention, which are actions that address environmental, socioeconomic, and behavioral risk factors. So for example, programs on food safety and nutrition guidelines, as well as campaigns discouraging tobacco and drug use. That goes even before you use it. That goes even before that. It's teaching. It's like education. These are primordial versions of prevention. Then you have your primary prevention, which are actions that inhibit the occurrence of specific diseases. So for example, vaccines, lifestyle modifications, fortification of salt with iodine to prevent iodine deficiency, fluoridation of toothpaste, water, and salt to reduce the risk of dental conditions, fortification of food with folic acid to reduce the prevalence of neural tube defects in women, health legislation, ocular prophylaxis for all newborns to prevent neonatal gonococcal conjunctivitis. So those are some forms of primary prevention. Secondary prevention are actions that inhibit the progress of specific diseases at an early stage to prevent or limit complications. So for example, screenings are secondary preventions because we're trying to get it early. Tertiary prevention are actions that inhibit the progress of specific diseases at an advanced stage to prevent or limit complications. So for example, adjuvant therapy to reduce the risk of cancer recurrence, blood pressure management to reduce the risk of a cardiovascular event, diabetes management to decrease risk of chronic kidney disease or cardiovascular disease. And then there's quaternary prevention, which are actions that prevent over-medicalization and offer ethically acceptable interventions. For example, avoiding hormone replacement therapy after menopause in order to reduce the risk of cardiovascular events. Avoid prescribing antibiotics if uncertain that the disease has a bacterial cause. Blah, blah, blah. That's preventive medicine in a nutshell. That's basically what this class is that I am taking. And I'm going to move my laptop over here because I feel like I keep looking so far out of frame. I don't mind being out of frame, but I don't want to be too out of frame, you know. So, oh my god, I thought my pretzels were about to fall. I don't want to spill my drink. Drink. Okay, so let's talk about some screening. So for hypertension is the disease that is defined as a blood pressure over 140/90, and kind of the definition of hypertension used to be quite controversial. controversial. It was like, are we going to define it as 135 over 85, or are we going to define it as 140 over 90? It's like, to me, it's like, it says if your blood pressure is in that range, you know, it's not amazing, so let's talk about it. It doesn't need to be fitting like that 100% criteria. Now, for clinical diagnosis for, let's say, clinical trials looking at hypertension treatment, I think that's different, but speaking from a clinical aspect, it's around 140 over 90. It is highest in our African American population, as well as some of the obese and overweight patients, and it is the most common diagnosed condition in outpatient visits. So basically, it is measured based on an average of 2 office blood pressure readings. The patient needs to be seated. They need to be allowed to sit for at least 5 minutes between the entry into the office and the blood pressure measurement. And it needs to be an appropriately sized cuff and placed on the patient's arm at the level of the right atrium during measurement, and it needs to be not over someone's shirt. It needs to be on bare skin. That is the best way. Okay. And then that's great. We can diagnose you in the office, but there is something called white coat hypertension that some people believe in, some people don't. I don't see why you wouldn't believe in it. But it's basically this idea that the office is quite a stressful time and a stressful place for a lot of people, so their heart rate is typically up from that anxiety, and therefore they're going to have increased blood pressure no matter what. It doesn't mean that it's pathological, it's just a temporary thing. And that's why the United States Preventive, let's talk about that really quick. Side note, it is preventive, not preventative. I looked this up. Preventative was just a word created, still socially acceptable. It is not correct, though. It is preventive. So if I say that wrong, it's because I'm trying to teach myself to not say preventative, even though my professor says preventative. My dad was the one who corrected me on that. I think he even talked about this in a video. Anyway, the United States Preventive Services Task Force found that there is convincing evidence that taking measurements of blood pressure at home is the best method for diagnosing hypertension, and that method is what we call ambulatory blood pressure monitoring, or home blood pressure monitoring. So, ambulatory blood pressure monitoring is where we have a small portable device that's going to measure your blood pressure over 24 to 48 hours and take an average of those, and that's while you're doing activities, so we can get a good overall estimate of what your blood pressure is at. So, the United States Preventive Services Task Force recommends screening every year for blood pressure, okay? And especially, for those patient populations that are at increased risk. However, it should be every year for patients over the age of 40. Patients with high to normal blood pressure, and this is anywhere from 130 to 139 over 85 to 89 mmHg, millimolars of mercury, milligrams of mercury, whatever. Overweight or obese patients in our African American population should be screened every 1 year. However, you're going to realize that a lot of times your blood pressure is taken no matter what, so pretty much everyone's getting screening every year. However, based on some studies following patients over time, adults aged 18 to 39 with no other risk factors have a very low incidence of getting hypertension. Therefore, they should be screened only every 3 to 5 years. Like I said, patients 18 to 39 years of age. And there should be confirmation outside of the clinical setting before a diagnosis of hypertension is made, like we said. A lot of the population has this white coat hypertension, okay? They actually say epidemiological data suggests that 15 to 30% of the population believed to have hypertension may have a lower blood pressure outside of the office setting. The disadvantages of diagnosing solely in the office are significant. Therefore, it needs to be confirmed outside of the clinical setting. And the minimal harms observed during outside clinical setting hypertension screening include a sleep disturbance, discomfort, and restriction in activities of daily living. So the benefits outweigh the harms in this situation. So that's our screening for high blood pressure. Next, we have screening for high cholesterol, or what we call hyperlipidemia. Okay, this is tested using a lipid panel, which is going to look at your total cholesterol or what we call the bad cholesterol. You need at least 2 measurements at different times to ensure that the true values are within 10% of the average of the measurements. So the United States Preventive Services Task Force recommends screening for men between the ages of 20 to 35, as well as women between the ages of 20 to 45, if they have diabetes, a family history of cardiovascular disease, family history suggestive of familial high cholesterol, or multiple coronary artery disease risk factors, which include tobacco use, diabetes, arterial hypertension, dyslipidemia, which is abnormal lipids, not necessarily high lipids, but abnormal lipids, high homocysteine levels, obesity, high fibrinogen levels, high phosphate levels, stress, increased alcohol consumption, males over the age of 45 years of age, as well as postmenopausal females. There is no established screening interval, so they don't know how often you should be screened, and there's no established age to stop screening, so they don't really know how often you should be screened or when you should stop. Most of the time I see it's pretty much every year for most patients. And I actually read, based on some of the trials, that drug treatment of 67 people for 5 years is required to prevent 1 coronary heart disease event. The American Academy of Family Physicians has a little bit different. I believe it's the same, though. Pretty much screening is recommended for all men over the age of 35. Men between 20 to 35 years of age with increased risk for coronary artery disease. Women greater than or equal to 45 years of age with increased risk, and women, obviously, 20 to 45 with an increased risk as well. Screening should not be done less than the age of 20 due to changes in hormone levels. You should recheck the levels in 3 months if they are abnormal and dietary modifications are made. Levels will not be fully changed, but you will get to see if they are changing a little bit. You should recheck the levels in 3 months if abnormal and medications are started. Levels will be fully changed based on medication effects at that time. And extending lipid panel evaluation to 6 months if levels are normal and maintained on a medication. So that is high cholesterol for y'all. Next we have diabetes screening. Okay. There are a couple different types of screening for high serum glucose or diabetes. But basically, the United States Preventive Services Task Force recommends screening as part of the cardiovascular risk assessment in adults aged 40 to 70 years of age who are overweight or obese. Not anyone else, which is crazy, because I would say that pretty much everyone gets a fasting blood glucose every year at their doctor's office, which, by the way, let's not even get into the fact that the recommendation for annual visits, like your yearly physical, you do not need to go yearly. The recommendations are out. It does not need to be yearly if you're pretty healthy, which is, I think, crazy, because I thought it was a given that every year you had to go for a doctor's appointment, but I guess not. And if you're diagnosed with diabetes, you are re-screened every 3 months if your levels are diabetic and you're on a medication or with lifestyle modifications. Levels will be moving in the direction they will be if with lifestyle modifications only. They won't be at the, kind of end of it. And then if they are normal, you should be re-screened every 3 years. Next is osteoporosis. If you guys are unaware, osteoporosis is a skeletal disorder characterized by loss of bone mass, microarchitectural deterioration of bone tissue, and a decline in bone mineral density or quality, leading to increased bone fragility and risk of fractures. So there's like normal, and then there's osteopenia, which is like you're starting to lose bone mineral density, and then there's osteoporosis. So there's some clinical assessment tools that you can use to see if you should get screened, and then there's screening. So most treatment guidelines recommend using bone mineral density as measured by a central Dexa scan to define osteoporosis and the treatment threshold to prevent osteoporotic fractures. So central Dexa scan is a measurement of bone mineral density at the hip and lumbar spine, and that essential Dexa is. And Dexa stands for Dual Energy X-ray absorptiometry. The United States Preventive Services Task Force recommends screening only for women. They've only ever done studies on women. It used to be men and women, but they realized that they have no evidence out there to prove that men should be screened for osteoporosis. So women over the age of 65, all women should be screened, and women less than 65 years of age who are postmenopausal and have greater than or equal to one risk factor for osteoporosis, which includes family history of hip fractures, smoking, excessive alcohol consumption, low body weight, as well as being postmenopausal. There is no screening interval established, and really this is all based on limited evidence from 2 good quality studies that found no benefit in predicting fractures from repeating bone measurements testing 4 to 8 years after initial screening. So it really should be more than 8 years after. So Dexa scan gives you what's called a T-score and a C-score. These are basically measurements based on standard deviations from the average or the norm. And so, because you're unaware with statistics, standard deviations spread out a normal bell curve. And you can pretty much, using a large enough sample size, you can pretty much say, like, it's going to be a normal bell curve, because pretty much everything out there turns into a normal bell curve when distributed normally. And so when you get to 3 standard deviations out, it's all based on the area under the curve. And so when you go 3 standard deviations out on both sides, the only area that's not under that is I think it's 5%, I think, or less than that. No, I think it's 5%. And so that's basically saying that if you're not within 3 standard deviations, like, the odds are that this is normal is 5%. It's pretty low. So that's where 95% confidence intervals come from. You're saying that we're pretty sure that it's within this range. The correct answer is within this range, or that the normal or the average is within that range. So T-scores are based off of a healthy person, like a normally healthy person. So if you are 45 years of age, it's based off of a 20-year-old's bone mineral density. So that's why it's a pretty tough thing. Versus a Z-score is in zebra. That is based off of someone who is age matched to you. So Z-scores are typically a little bit better of a measurement. However, to define osteoporosis, you have to have a T-score of less than or equal to negative 2.5 outside. So that's outside. And then your Frax score. Frax is a tool that assesses a person's 10-year risk of getting a fracture. That's what Frax stands for. And so your Frax 10-year probability of a hip fracture needs to be of at least 3%, and any other major fracture of at least 20% to be usually treated for osteoporosis. Rescreening for someone with osteoporosis is every 2 years. Osteopenia, which is between -1 and -2.5, or maybe even 0 and -2.5, that is every 5 years. And then a normal bone or mineral density should be screened again in 10 years. And like we said, someone with a normal thing, it was shown with good evidence that rescreening in, what did I say, 4 to 8 years, it showed no benefit. So it's good that it's 10 years. So that is osteoporosis. The treatments for that, we won't even get into that. Bisphosphonates, things like that. So we don't get into that. But next is colon cancer or colorectal cancer screening. It is the 2nd most common cause of death in the United States. It's a pretty serious thing. But what's interesting is that nearly 33% of eligible adults have never been screened for it. And I'll tell you why. Because the data out there is amazing on it. There's so many different methods. There's stool-based methods, and there's direct visualization-based methods. So looking at the stool, we're basically going to measure for blood. Most of our left-sided colon cancers, which is where they mostly are, you're not going to really see blood necessarily. You're going to see more stool changes, but things can bleed, and that is why we test for blood. you wipe after a really nasty shit and it's got red streaks in it, most likely it's a hemorrhoid. It's probably not cancer. Just want to put that out there. So there's something what's called a guaiac fecal occult blood test. This is where we take a stool sample, typically after doing a digital rectal exam or a rectal exam, and we wipe our finger with the stool on it on these cards, and they will turn blue if they're, I believe, blue if there is blood in the stool. However, there's many different possibilities for having false positives. Eating any kind of other red meat in the days before. I know some medications can cause false positives, so it's not a super specific test. It is more of a sensitive test. So sensitive means it would pick up anything cancer related. Specific means it says if it's positive, it means it's that cancer, but it's not specific. It could be false positives from other things, so it's not specific. And multiple randomized controlled trials have shown that screening with guaiac fecal occult blood reduces colorectal cancer deaths, which is a really big feat. It's not our number one goal for cancer screening. Our number one goal is reducing all-cause mortality, but not many. I don't think maybe even one of our cancer screenings does that. So this is the second biggest thing that we need to do. So after they came out with the guaiac fecal occult blood, they then came out with what's called the immunochemical fecal occult blood test, or FIT. We call it the FIT test. This is an improved sensitivity compared to the guaiac fecal occult blood testing for detecting colorectal cancer, and it has less chances of being false positive. So there's not as many things that you can't eat or drugs that interact with it, because it's testing like the DNA of the blood. It's an immunochemical test as opposed to a guaiac-based reaction. And so both the guaiac-based fecal occult blood and the immunochemical fecal occult blood would have to be tested every year for colorectal cancer screening. And the last test for stool-based tests are combining that FIT test as well as a fecal DNA test. And that together is what we call Cologuard, which you've probably seen of on commercials. This is used every 1 to 3 years. It has a higher single test sensitivity compared to the FIT alone because of that DNA portion. However, there is a higher false positive rate than the FIT by itself, and a higher rate of unsatisfactory samples than FIT itself. And information is lacking on appropriate screening intervals as well as follow-up intervals who have a positive FIT DNA but a negative colonoscopy. So one thing to know, if any of these come back positive and we don't think it's a false positive, our next step would be to get a colonoscopy, and we'll talk about colonoscopy in just a second, but it's just good to know that. So next we have direct visualization tests. The first one is what we call the flexible sigmoidoscopy. A sigmoidoscopy is a camera that goes in through your rectum. This is not something you have to be put under for. This is not a surgery. It can be done under twilight anesthesia. However, it is like an office-based procedure. You can be awake for it if you want. And it is going to look up. Let me see if I can do I can't. It looks up and a little bit across, but that's about it. It can't do much more than that, versus a colonoscopy can look up, across, down, even into some of your small intestine if needed. So sigmoidoscopy can look at not the whole colon. The colonoscopy can. Flexible sigmoidoscopy would be tested every 5 years if you were going to use just that. But again, if they saw anything on it, they would then have to do a colonoscopy. Okay? Next, you could combine a FIT test, which we talked about earlier, the immunochemical fecal occult blood, with a flexible sigmoidoscopy. You would do the FIT every year, but then you could do the sigmoidoscopy every 10 years. And a single trial studied the combination and found that the combination reduced colorectal cancer-specific mortality more than flexible sigmoidoscopy alone. So that's why that is a possibility. And then we have what is considered in the medical field the gold standard. Oh, by the way, I want to say something. Like we talked about with the guaiac fecal occult blood, guaiac fecal occult blood showed a reduction in colorectal cancer mortality. Flexible sigmoidoscopy did the same thing. Several randomized controlled trials have shown that flexible sigmoidoscopy alone reduces deaths from colorectal cancer. So, pretty big. colonoscopy. And a prospective cohort study found an association between self-reported colonoscopy screening and a lower colorectal cancer mortality rate. However, there has been no randomized controlled trials that showed a reduction. It is just like asking someone, have you had a colonoscopy? Oh yeah, I have. Oh, have you ever been diagnosed with colorectal cancer? Oh no, I haven't. And so based on that, they basically were like, oh, people who get colonoscopies don't have as much cancer. So, colonoscopy is cool. For one thing, it looks, but it can also treat, which is why they love it. The medical field loves it. We would go in and visualize, and if we see any sort of polyp, we can take a biopsy, we can take it out, we can analyze it. It is a 2-in-1. Every single other screening option here, you would screen with it, and if it were positive, you would then have to get a colonoscopy to have it removed. That is our only treatment option for removing polyps. Versus just doing a colonoscopy on its own. It's one and done. It's a one-stop shop. Okay? This is more of a inpatient procedure. You're in the morning, out by the afternoon type of thing. You can be under for it. You don't have to be under for it. You can just be in like a twilight anesthesia. If you wanted to be like more knocked out, you could talk to your anesthesiologist about that. So that's that. Colonoscopy, you have a prep for it. You have to, have laxatives, not eat as much the day before, so you don't have to have as much diarrhea. That bowel prep, you have to be out from work in the morning. You have to, so there's a little bit more preparations, and there's a little bit more complications associated with colonoscopy. And there has been no real study out there, no randomized control trial to prove its efficacy. So that's what I have to say about colonoscopy. The United States Preventive Services Task Force recommends screening for everyone between the ages of 50 and 75. Younger, if you have a higher risk of it. For example, our African American population has a higher risk of colorectal cancer. They may want to get screening at 45 years of age. If you have a first degree relative who has had cancer before, maybe at 40 years of age, you would want to start it 10 years below that. If they had colorectal cancer at 50, you would start it at 40. It's typically 10 years before when your first degree relative had it, unless you usually are at 40 or 10 years before that. So if they were at 60, you wouldn't start at 50 because we would start at 50 regardless. So you would start at 40. So if you have a first degree relative, it's 40 or below that you would start. The benefit of early detection for colorectal cancer decreases after 75. That is why we do not recommend screening after the age of 75. However, if you're a really healthy, up and at 'em adult, geriatric patient, really, and you wanted to still get screening, and your life expectancy, if we assumed was greater than 10 years, absolutely, between the ages of 75 and 85, we can still get colorectal cancer screening. But at the age of 86, we do not recommend it for anyone anymore. The harms of screening in adults are mostly from colonoscopy complications. There is another option, which I didn't mention, something called CT colonography. This is where we basically take a pill. Well, there's two different. There is a pill that you can swallow that has a camera that can look, and there's another option, CT colonography, where they take a CT scan of your entire body. Okay, but the thing is, I don't know if it's the entire body or at least the abdomen area. I think it's just like the abdominal area to the pelvis. They can detect other things on there, right? They could see like a pancreatic cancer or something. So there are risks of finding other things that are not of importance, but that they have to go and figure out. So it is overdiagnosis and overtreatment for CT colonography. So they say that in about 40 to 70% of patients screened with CT colonography, about 37% of these findings were resulted in diagnostic follow-up, and 3 resulted in definitive treatment. So that's that. Like I said, the only 2 things that have really shown a result in reduction of colorectal cancer mortality in randomized controlled trials are the coag fecal occult blood as well as the flexible sigmoidoscopy. Sorry about that. My brother just came in. Next is lung cancer. Lung cancer is the third most common cancer in the United States. It is the cause of 28% of all cancer-related deaths in the United States, and 30% of U.S. adults are current or former smokers. So 90% of patients with lung cancer will die of the disease, and the incidence appears most in patients greater than the age of 55. Smoking is the number one risk factor for lung cancer, and there are a couple screening options. The one we're going to talk about is what's called a low-dose CT scan, or an LDCT. The United States Preventive Services Task Force recommends screening every single year with a low-dose CT if you are between the ages of 55 and 80. You have a 30-pack year history of smoking, meaning if you smoked a pack a day for 30 years, or you smoked 2 packs a day for 15 years, or 3 packs a day for 10 years, that is a pack year history. And you need to currently smoke or have quit within the past 15 years. Screening should be discontinued once you have not smoked for 15 years, or you develop a health problem that substantially limits your life expectancy or the ability or willingness to have curative lung surgery. And I want to tell you what's interesting about this. This criteria for who can get a low-dose CT was based off of one singular study that showed that it reduced mortality and all-cause mortality, right? And so that was the inclusion criteria they listed. Only patients between these ages could be in the trial, only patients who have smoked within the past 15 years, only patients with a 30-year pack year history, and so therefore that's what caused, that's what led to them having this as the criteria needed for you to be screened for it. Harms include false negative and false positive results, incidental findings, overdiagnosis, and radiation exposure. 95% of all positive low-dose CT results do not lead to a diagnosis of cancer. Very high false positive rate. 10 to 12% of positive low-dose CT results would not have been detected in the patient's lifetime, meaning they would have died without any knowing symptoms or anything like that. So this is where it gets interesting and tricky. And this is fucking The American Academy of Family Physicians said, excuse me, United States Preventive Services Task Force, you're basing this entire guideline off of one singular study. That is ridiculous. And so the AAFP says the evidence is insufficient to recommend for or against screening for lung cancer with low-dose CT in patients at high risk for lung cancer based on age and smoking history. They have significant concern for the United States Preventive Services Task Force basing such a far-reaching and costly recommendation on a single study, the National Lung Screening Trial, or the NLST. Not the family being loud. So that's that on lung cancer screening. Very interesting, I think. Cervical cancer is the next, if you did not know. This is for women as well as men who still have a cervix. Okay. Screening is not recommended for anyone below the age of 21. Okay, this is because, well, let's talk about cervical cancer and HPV really quick. HPV is a sexually transmitted disease. Okay, we are not looking down on anyone with a sexually transmitted disease or infection. action. Do you understand me? That's over with. It's 2021. We're not doing that anymore. We're not shaming anyone, okay? This is a virus, and just like any other virus, okay, it is benign until it's not, okay? And so this is the issue. HPV attacks the cervix, and the cervix in young women and men can quickly shed skin, shed the lining of the cervix, and therefore no issues will be had after the age of 21, between the ages of 21 to 29, starting at really 30. That slows down to the fact that the HPV will infect those cells and possibly turn them into cancer. That is why screening is not recommended before the age of 21 with a pap smear or anything, because there will likely be abnormal cells, but guess what? Your body's going to get rid of them anyway. They're actually shifting. They want to move it up to 25. Now they're realizing that the risk between the ages of 21 and 24 aren't really that, or the risks are higher than the benefits. But let's get into it. So there's a couple different testing. Cervical cytology, or what we call pap smear. This is us taking a sample and we're looking at the actual cells, okay? Then you have HPV testing. We can test for the HPV strains. There are specific HPV strains, and I can list them for you. Okay, 16 and 18 being the most common. Those are the most serious strains of HPV. We can test for that, and we can also do a combined. It's what's called co-testing. We look at the cells, and we also test for HPV at the same time. Okay, women between the ages of 21 and 29, according to the USPSTF, should be done every 3 years with cytology alone. You should get a pap smear every 3 years, as long as it's normal. Okay. Between the ages of 30 and 65, you should get cytology or pap smear every 3 years, HPV testing every 5 years, or co-testing every 5 years. Okay. Women over the ages of 65 with adequate prior screening should not be screened anymore. Shouldn't. Women who have had a hysterectomy, with a total hysterectomy with their cervix also removed, should not should not be screened. Both HPV testing and co-testing would avert one cancer case per 1,000 women screened, but also subject women to more tests and procedures. Harms include vaginal bleeding, pain, infection, and failure to diagnose. Of course, there's risks with anything. Some have actually come out and said that, like I said, between the ages of 21 and 24, the risks are more than the harms. And I just want to say that HPV in patients less than or equal to 29 years of age is expected. Like I said, HPV is really expected in all age groups, but you're most likely to get away, or like to get rid of it on your own before the age of 30. Once age of 30 starts, the risk of HPV causing cellular changes is much higher. And I believe the last cancer prostate cancer. So prostate cancer is an interesting one. A lot of changes happened, in our time. So prostate cancer is diagnosed or screened in a couple ways. We can do a digital rectal exam, feeling in through the anus, feeling the prostate. We can also do something called a prostate-specific antigen test. This is a blood test that looks for a specific antigen that's on the prostate. Higher levels would indicate more irritation to the prostate, but that's not necessarily true. We have found that there are many false positives for a high or a rapidly increasing PSA. UTIs, like a urinary tract infection, okay? BPH, or benign prostatic hyperplasia. Men can just have bigger prostates as they age. Men with big prostates. So there's many reasons. This is, like we talked about earlier, a sensitive but not a specific test. Therefore, we stopped our universal screening for all men with PSA. Okay, so now the recommendation by the USPSTF is men ages 55 to 69 should have a conversation with their physician, PA, nurse practitioner, advanced. What is the APA? Advanced APP, advanced practicing practitioner, whatever. I should know that, under that umbrella. It should be an individual decision between you and your medical provider. Screening offers a small potential benefit for reducing the chance of death from prostate cancer in some men. However, many men will experience potential harms of screening, including false positives that require additional testing, and possible prostate biopsy, overdiagnosis and overtreatment, and treatment complications such as incontinence and erectile dysfunction. Men over the ages of 70 should not be screened. There is a Cochrane review that prostate cancer screening did not statistically significantly decrease prostate cancer-specific mortality. Only one study reported a 21% significant reduction of prostate cancer-specific mortality in a pre-specified subgroup of men ages 55 to 69. Isn't that's tea? That's why we say it. Prostate screening, though, did not result in a statistically significant reduction in all-cause mortality. This result did not differ when the data from this pre-specific subgroup of men 55 to 69 were used. So, like I told you, that's our really gold standard for cancer screening, and not a lot of screenings do that. And the last is breast cancer. I believe this is the last, and this is really the most controversial in my eyes. Breast cancer is a very prevalent disease. 1 in 8 women will experience breast cancer at some point in their lifetime. 1 in 39 women with breast cancer will die. Okay, it's very prevalent. It's a serious disease. Okay, but this is the thing. We don't have a crystal ball. Okay, and the methods we have right now are not flawless. Actually pretty flawed, if you ask me. The number one most commonly used screening method is mammograms or mammography. This is where women place their breasts on a plate. They are squeezed and imaged. Okay. This is typically done every year or every 2 years once the age of 50 hits, or in some recommendations once the age of 40 hits. And this is where the tea ensues. It used to be universal that every woman over the age of 40 would get a mammogram every year. And then data came out to show that between the ages of 40 to 50, the risks are higher than the benefits. Okay, and therefore, the decision to perform screening mammograms should take into consideration the individual patient's risk, values, and comfort level of the patient and physician. Rates of false positive results in young women were nearly double in those than in the women greater than 50. The number needed to screen for women less than 50 to prevent one breast cancer death was much higher than that for women 50 to 59 and 60 to 69. And the risks of overdiagnosis and overtreatment were additional risks and harms. Therefore, the United States Preventive Services Task Force recommends that I believe they recommend 50. However, 50, you should be screened every 2 years. Controversial. People think every 1 year starting at the age of 40. Crazy. After 75, there's really no recommendation. That's again something you should talk to. Breast cancer is the second most common cause of cancer-related death in women in the United States. It is the most frequently diagnosed between women ages 55 to 64, and the median age of death from breast cancer is 68. The United States Preventive Services Task Force found adequate evidence that mammography screening reduces the breast cancer mortality in women ages 40 to 74. However, the numbers of breast cancer deaths averted increases with age, meaning that women ages 40 to 49 benefit the least, and women ages 60 to 69 benefit the most. The American Academy of Family Physicians differs a little bit. For average risk women ages 40 to 49, the risks and benefits of mammography are closely balanced. Therefore, the decision to perform screening mammography should take into consideration the individual patient risk, values, and comfort level of the patient and physician, and a lot of the similar things. Therefore, annual or biennial, meaning every year or every 2 years, screening should be offered to average risk patients ages 50 to 74. But this is where the date comes in. The Cochrane review, which we've talked about before, evaluated that breast cancer mortality reduction is 10% in the most reliable trials and 25% in the least reliable trials. Since unreliable trials usually overestimate the reduction or the effect, the reduction was most likely estimated to be around 15%. The United States Preventive Services Task Force had found a reduction of 16%. Together, this means that regular screening of 2,000 1,000 women for 10 years would save the life of one woman. Now, if that was just the tea, I'd say do it. If that's all it is, if we're at least saving one person for every 2,000 women, I would be so happy. But this is the issue. 10 women will be treated unnecessarily. These women will either have part of their breast or their whole breast removed, and they will often receive radiotherapy and sometimes chemotherapy. And 200 women will experience prolonged psychological distress related to false positive diagnoses. Therefore, screening really doesn't reduce the overall risk of dying or the overall risk of dying from cancer, including breast cancer. Therefore, it seems that women who go to screening do not live longer than women who go to screening do not live longer than women who do not go to screening. Since the randomized controlled trials were carried out, though, there have been important advances in diagnosis and treatment. This means that the effect of screening is smaller today, even more so. In fact, more recent rigorous studies suggest that screening is no longer effective. Therefore, I'm saying this. They need to reevaluate mammography. There are some newer, better ways for using mammography. I was learning, I think it's like SPECT or something. There's like a different kind of mammography screening. But mammograms on their own don't seem too good, in my opinion. That's what I've got to say about that. Listen, we're 47 minutes in. Maybe I should do another video and talk about vaccines. I'll do that. Alright. I hope you guys enjoyed this video. I'm going to quickly go through some vaccines in just a little bit. If you're interested in that, please go watch that video and please check out my Patreon. I'm not amazing at posting there. I'm going to be honest. I'm trying my best. Hopefully when this panoramic shuts down, I will get my motivation back. But in the meantime, I'm sorry. I love you guys very much and I will talk to you soon. I hope you enjoyed this video. I love you.